Before you just threw that big gun over here.
Ready to roll? All right. August 31st, hallelujah, y'all, we made it to the end of August. Won't be long now. Workshop today. Our agenda is health insurance for employees and retirees. And we have our friends from Gallagher here with us today. They give us some ideas about what we're doing. And mostly it's a presentation, but I'm sure there's opportunity. So, y'all ready to go? I'm ready to go too.
All right, do you want me to go up there so that Leon can see me?
I think your camera.
Can you hear me? I come up there.
Yeah, come on. Didn't realize it was aiming this way.
Cool. Well, for those of you that don't know me, I'm Chuck Robinson with Gallagher Benefit Services. We went out to market for the medical, stop loss, retiree medical, and dental earlier this year. And we've got the results back. We wanted to just have a workshop to kind of give you a heads up as to some of the things that we received back and some things that we're considering, and then get feedback from the commissioners as to kind of what direction you want to go. The intent would be to get that direction, then make a recommendation at the September 14th Commissioners Board meeting as far as, the plan changes and what we're going to do for the upcoming plan year 2022. The three things that I want to talk about today just is one, specific to the retiree medical coverage. We've currently got a plan that's in place with Benestar. We've had it in place for about 3 years. It's worked really well. The retirees have been very happy with that. And they came back with a slight decrease from where we are now. That being said, we do have an option on the table that has some significant savings through Blue Cross Blue Shield. And so I want to talk through kind of how the differences are between the current medical plan and what Blue Cross Blue Shield is offering. We do have somebody from Blue Cross Blue Shield that's out here to kind of answer questions about how their plan works and how they help support that and what it would look like compared to what we currently have with the Benestar plan. And then we've been continuing to negotiate with Benestar, and at 7:15 last night, I got an updated proposal from them that's a very attractive option as well. So I'll walk through some of those. I want to get feedback from you guys and answer any questions that you have so that when we come back to the commissioners on the 14th, we've already kind of given you a briefing on that. You understand what we're looking at. Also want to talk about rates or contributions for the retirees, and then we'll switch gears and look at the Blue Cross Blue Shield self-funded plan and focus more so on what we're wanting to do as far as shifting cost or increasing contributions to employees or making plan design changes and what those contribution changes, what that would look like. So we'll start with the retirees. Any questions before we get started? So.
Question.
Yes. Yeah.
Say, can you hear me, brother?
Sure.
Okay, so you're starting with the current medical plan on retiree.
I'm going to start with the retiree plan. That way we can bring in Blue Cross and answer any questions, and we can let that gentleman, go once we're done talking about the retiree options, and then we'll switch to the self-funded medical plan option.
Thank you.
And I can point out, I actually brought two of my colleagues with me, Brandon DeBar and Lindsay Soccer, work with me on this account. They help with all the marketing and putting together the different presentations. And so I'm not a team of one. I've got a whole team helping support Liberty County and an additional team of folks back at Gallagher as well. So thanks, guys. Leon, I'm sorry I don't have any electronic copies, but I'll send you this afterwards. Who else needs a copy? I brought All right. So what we're looking at here, the first page here is essentially the status quo. So Hartford Benestar is a Medicare supplement plan, which means Medicare's primary. Anybody that's enrolled in this plan, all the claims are filed through Medicare first, and then whatever Medicare doesn't cover, the supplement plan fills in the gaps for that. So there's a member deductible and up to a $2,000 maximum, but it's a very rich plan that we've had, and the retirees like it. There's no changes to this plan design. The only changes each year are when Medicare changes what they reimburse, the plan adjusts so that it fills in the same cost share on that. And you can see down on the bottom right-hand corner, to keep the same plan design, it's almost a 1% decrease, but we're not talking a significant change. It's about $2,500 decrease over current. So they came back with a very competitive option. But then the second page, we're looking at what's called a Medicare Advantage plan. So the difference between Medicare Supplement and Medicare Advantage is Medicare doesn't like to have to adjudicate claims. They would much rather have an insurance carrier take on the risk and manage the claims. And so all the different carriers offer Medicare Advantage plans. And we had a Medicare Advantage plan prior to moving to Benestar back in the day, but it was subject to a network of doctors that were part of, I don't remember the carrier that we were with, but essentially the retirees, there's a lot of noise because they couldn't access all of the doctors that, they couldn't see necessarily their doctor if they weren't in the network. So one of the constraints or one of the requirements that we put in place, if anybody wanted to propose a Medicare Advantage plan, was that it had to allow retirees to access anyone that accepts Medicare assignment. So both of the plans that we're looking at here, Blue Cross and Benestar, Benestar is actually quoting the Cigna medical piece. They have the ability to go see any doctor that accepts Medicare assignment. So they don't actually have to be in Cigna or Blue Cross's network. They just have to be willing, the doctor has to be willing to bill Blue Cross, and then they will get paid the same amount that Medicare would have paid. So right now, retirees have their Medicare card. They've got a Hartford card, which is that fills in after Medicare stops paying. And then you've got your Express Scripts, which is your pharmacy benefit card. And that fills in all the gaps. Blue Cross Blue Shield, their plan is a very rich plan. It shows a deductible, but all of the items that they have are subject to copays. There's actually no items that are subject to deductible. So most of the services are a $0 copay, there's a $50 copay for emergency care. So the real focus is with Blue Cross is where's the catch? What's going to be the noise that we create? Because we're looking at $250,000 worth of savings because the rate here is only $118.60 per belly button covered under the plan. Where if you look at the current costs, we're looking at $322. The reason that there's that much savings is Medicare actually pays Blue Cross $800 for each person that's enrolled in the plan, on top of the $118 that they collect from Liberty County, and then Blue Cross takes on all of the risk. The biggest concern that I have with this plan is going to be with regards to the pharmacy. And there's not a real good way for us to know how much disruption there would be, but anytime you make a change from their current pharmacy benefit, which is with Express Scripts, to the Blue Cross formulary, there may be some prescriptions that are not covered that retirees are currently taking. There's usually some disruption when you make that type of a change. Because the group is as small as it is, we've only got, I think, less than 100 employees that are actually enrolled in this benefit. We can't get a disruption report from Express Scripts to have Blue Cross run that disruption. The other piece is Blue Cross now takes the risk. So the way they manage the claims, there's a little bit more managed care. And so there may be some frustration from the retirees as far as how the plan administers or requires them to, do step therapy or receive different types of treatment on the plan. So, significant savings on that one, but it does come with potential noise with regards to how the retirees use that benefit. But feel like it's a significant enough amount of savings that we need to at least look at it and then open it up to questions for Blue Cross as far as how that plan runs. The other piece that we got, like I said, last night, late last night, I've been talking back and forth with Benestar, explaining that we've got a Medicare Advantage plan that we're looking at with Blue Cross. Cigna owns Express Scripts. That was something that they acquired a couple of years ago. And so Benistar was able to go to Cigna and say, hey, we want to take a look at a plan just like what Blue Cross is offering, which is a Medicare Advantage plan, open access. So retirees can still access doctors that accept Medicare assignment. So you should be able to see the same doctors that they're seeing right now. But keeping the formulary or keeping the RX benefit the same. So there's zero change to the formulary or the RX benefit. So this benefit, this option on the right-hand side, there is no change. There would be zero disruption from what we currently have under the current Benistar plan. But the savings is based on the fact that it works the same way. The medical is only, that $22, and that includes, the broker, it's really $12 that's going towards that medical, and then they're getting the remainder of that from Medicare, that $800 a month. So the lion's share of that $170 is the pharmacy piece. So I think it would be worth considering also if we're wanting to try to look at the savings, taking a look at that Cigna Benistar plan. Any questions for me? And then I'd like to bring in, Blue Cross to just kind of go through how their plan works, and we can kind of ask questions of them and then open it up for additional dialogue.
Elia, you look like you got questions.
I'm saving them.
Okay, all right.
Okay.
Penny, how about you? Yep.
Good right now.
Okay. For the purposes, I'd like to try to, we're not going to talk about the other options and what we got back when we bring Blue Cross in to talk about, their proposal. But I appreciate them making the drive out here so that we can kind of ask them some questions about, their plan. I'll go ahead and have him come on in, and then we can also discuss the retiree contributions and move on to the other. Leon, did you have any questions?
No, thank you.
I just texted him. I'll pass this out here. Keep one for him as well. And then pass those guys. All right. So as far as Benistar is a CPA, they actually provide a lot of additional services by administering the plan. So the customer, retirees actually call into Benistar. They're able to get welcome kits and a lot of other makes using the plan a lot easier. So some of the questions that I asked Brian to speak to was specific to how Blue Cross would take over that piece. And Brian, come on in. I want to introduce Brian from Blue Cross Blue Shield. We've got commissioners, judge. Fred, you come on up. It's pretty informal. We're just we walk through there we got Leon online, so the microphone, but really just wanted to open it up to some questions, have you maybe speak to just how the Blue Cross plan would work similar to what they're currently using and expecting with Benistar, as well as from an administration, but keep it at that high level just so that, and then we can open up for questions.
Okay. First, thank you all for the opportunity to come out.
Thank you for coming.
But first, thank you all for having me. I appreciate the opportunity to visit with the county and interested folks. This is a different program than what is set up currently with the Benistar program. It is a Medicare Advantage program rather than a supplement type program. And I mention that because there is a distinction there. I want to try to keep this up at a high level. But it's, everything would now come under the umbrella of the Blue Cross plan, the Medicare Advantage plan. You don't have a separate medical plan, drug plan, and then Medicare. Everything coordinates under the insurance company. It's an all-encompassing program. So what that does for the retirees, one, is it simplifies the process for them. Okay, it gives them, they have one card now that they use rather than possibly three. Okay, it is a federally regulated program overall. Currently, with the existing program that you have set up, the supplement plan is actually overseen by the state, and the drug program is overseen by CMS or Medicare. With this program, again, everything comes in under a single umbrella, and the entire program is regulated at the federal level rather than at the state level or through Texas Department of Insurance. So it's designed to, one, hopefully simplify the process a little bit. Two, and I don't want to get in the weeds, and I was instructed not to get in the weeds, so I'm going to try not to. But it's a Medicare Advantage program is a program that is designed with the member in mind first. Okay, and by that, what I mean is their interaction with the insurance company to make sure that they're doing things that we're hoping that they're doing things they should be doing. Taking your meds, getting your PT, any kind of therapies, anything like that. We're reaching out to the members. So we're a little more involved under the current program, and there's nothing wrong with the current program. Don't get me wrong. It's we have offered those sorts of arrangements in the past, but the member is pretty much on their own. Okay, and with an Advantage program, we try to help them to ensure that their quality of life is where it should be as we age. Because, and I'm finding this out the hard way, growing old ain't for sissies. And we want to help your members, help your retirees as they go down that path as we get a little bit older. Basically, what I'd like to do is just answer any questions that any of you up here may have, or anybody out here may have, with regards to the program.
Brian, let me tee some up here. Some of the things we discussed. So, as far as a retiree experience, what does Blue Cross do prior to? So, if you 15 days prior to open enrollment, Blue Cross.
Okay.
Walk us through that process, and then also, I already kind of went through the fact that anyone that accepts assignment, Medicare assignment, and is going to bill Blue Cross, there are going to be doctors that are going to say they don't accept Blue Cross. So how does that look as far as what Blue Cross is going to do to help make sure that's as smooth and seamless for the retirees?
Okay, great. The first part of that, what's this look like at the member level from the inception? And essentially what we're going to do is, if we were awarded the business, first of all, we're going to have an implementation process with whomever on the benefits committee, the commissioners, whoever wants to be involved with that, along with the folks from Gallagher. And we're going to go through literally the soup to nuts, down to the level of who are the contacts at the county that we're going to be working with, phone numbers, hours of operation, a granular level implementation of the program. And at that stage, we're reviewing all of the details here, for the plan of benefits, so on and so forth. We start that process as soon as we're awarded the business. One of the items that is discussed at that time is, what does the county do for their open enrollment? Okay. And there's an initial enrollment and then there's ongoing enrollment. I'm going to talk specifically to the initial enrollment. You tell us, and I'm using this as an example, but you tell us that we're going to open up the process, say November 1st through November 30th. So what we do is we have a vendor that we use, we call it, and it's called the education line, where the retirees can begin 15 days prior to that open enrollment start date. In this case, that's approximately October 15th or 16th. They can begin calling in and talking to folks that have all of the plan information. They can call in and talk about docs. They can call in and talk about medicines. They can talk about, I'm in the middle of X, and they'll talk about a transition process with them with respect to their situation. They can talk about general plan provisions, i.e. if you go to the doctor, your copay, an office visit is X dollars. If you're in the hospital, this is what your cost would be, if you're in there. So basic plan provisions. They do not necessarily they don't get into the weeds either unless they have to, as far as projecting certain things. They're going to talk about the plan provisions that we have in place. You run a risk if you get in too deep in a hypothetical situation, but we're going to give them all the information they ask for prior to them looking at any kind of paperwork to sign or anything of that nature. Because even with our program, just as they do right now, they can choose to participate in the retiree program or not to participate. We certainly think that it's a program that has the value for them. But that's the decision they're going to make is, do I go in this plan or do I leave the county umbrella, So it's not, do I take the high plan or the low plan? It's, am I going to stay with the county or not stay with the county? That's the thing. And we're going to give them all the information that we can regarding the benefits that are going to be in place for them. We're also, as part of this implementation, we're going to work with the county on what your needs are going to be. Do you want to have virtual meetings? Do you want to have in-person meetings where the retirees can come in and we come out and talk about the program? We're going to work with what your needs are. Okay. We're still kind of going through some of this COVID thing, so we see a lot of different reactions from a lot of different employers. Some, they don't want any in-person contact right now, and others do. So we're going to work with you to set that up as well so that we can, again, meet the needs of those retirees. And if it's 2, 3, 10 meetings, again, whether it's via a Zoom call or whatever vehicle you might want us to use, we make those arrangements with you so that we're available in particular during that open enrollment period to assist them in the process.
I think that covers, the question as far as just, so, and Brian and I had a nice long conversation, so I'm going to kind of tee it up. I want to get to some of the questions, but essentially prior to enrollment, there's going to be a phone line set up. That's education phone line that you discussed. There's welcome kits and documentation that would be sent out to there's also documentation that's sent out to the providers or to the retirees about the benefits. I think in the packet here towards the back, there's just some screenshots of the different enrollment brochure and some of the information that would be sent out to the retirees. And then after the fact, so once they're in the plan, let's say we've got a retiree that goes to a doctor that they've been seeing and that doctor's like, not in network with Blue Cross. It's my understanding that Blue Cross, there's a process where the retiree can have Blue Cross reach out to that provider, and it's an education process. Because that provider might not actually be in Blue Cross's network, in any of the networks. They might not be contracted with Blue Cross. This plan works differently in the sense that it's not about a contract that the provider has with Blue Cross. They just have to be able to accept Medicare assignment and be willing to bill Blue Cross. And so a lot of times it's a conversation with that provider about that process, and then they're able to get it worked out so that that individual can continue to see their doctor because they don't have to be in Blue Cross's network. This plan is an open access plan.
And to take off on that, the other thing that we typically do with these type of programs is we actually provide a letter in the welcome kit. It's not part of our standard, so you may not have seen it in the slides, but it's a letter that your retiree can take and give to their doctor. In that scenario where they say, well, I'm not in the Medicare Advantage network. Here's the letter. This explains how it works. And here's a number for you to call Dr. Smith to talk to one of our folks, and they'll review payment with you. And here's the thing to remember, and that is this, and that is any doctors that your retirees are currently seeing, they're accepting assignment from Medicare. Because when that retiree goes in, they give them that card with the medical information on it. And then they submit that to wherever that PO box is for payment. So they're accepting assignment right now from Medicare. I will tell you, because it always does happen, there's going to be a doctor who says, we don't play with Blue Cross Blue Shield. So that can happen, but we work with them and contacting them and explaining them, you're going to get paid the same exact thing that you got paid before, under this program. It's not anything different. But we cannot prevent a doctor from not accepting assignment. I have had occasion where there is a group or a doctor that, for whatever reason, they may have a burr under their bonnet about Blue Cross. It happens. It's not frequent. I've been in the Medicare space since 2007, and I can count the instances on one hand where it has occurred that I've run into that scenario. It's probably 2 or 3 times, but it is something that can happen. If your retiree comes to you, you come to us, we'll reach out to that particular provider and walk them through the process. And they still ultimately have the decision to make whether or not they want to go ahead and accept it. But they're getting paid the same from us as they were getting paid before. So it's just a matter of, they have all the information on the ID card. You submit the claim and you're going to get paid. And actually a doctor gets paid quicker with a Medicare Advantage program, and here's why. I'll get into weeds for 1 minute. Under Medicare, what happens is Medicare processes claims in what they call batch bill. They wait until it's either a certain dollar amount from Dr. Smith or it's 6 inches tall, whatever, and then they process weeks and weeks and weeks and weeks and months of claims. Then only after Medicare pays it does it then go to the Benestar provider for them to pay the remainder of it. Under Medicare Advantage, typically a claim is paid because doctors, they might submit daily, they might submit weekly, depending on how big their practice is. But that claim gets processed usually within 10 days from the time it's submitted. So it's actually, it's more helpful to the providers under a Medicare Advantage than oftentimes in a supplemental type of arrangement. I'll get out of the weeds.
And we've got, I think from a time perspective, I want to make sure if there's any questions, while we've got Brian here, I'd like to open it up questions about the plan, or if you have any concerns or.
Will there be,
Right, Leon?
will there be any additional new cost to the retirees with this program?
I mean, so it just depends on, whenever you make a change like this, prescription drugs, there could be a potential, there's probably more chance for disruption as far as, a drug that they're currently taking not being under the new formulary. There is some information on the formulary that's being offered with this plan. Blue Cross has their broader formulary, so it's not their standard. They do have the enhanced, larger, more robust formulary that's being included in the package, but additional costs to the retirees would be more so a function of if their doctor just decides they're not going to bill Blue Cross and the formulary, because they reimburse at the same rate that Medicare reimburses. So the plan's going to pick it up. Matter of fact, I think plan design in itself is actually a richer plan than what we currently have with Benistar, where there's 0 items that are subject to the deductible. It's just copays. It's a very rich benefit that they offer. It's one of the richer ones, which is Medicare pays Blue Cross a certain amount based on how rich the benefit is, and it's at that top tier. So they're getting that highest reimbursement from Medicare because of how rich the benefit is.
Thank you.
Delia, you had a question?
Did I understand you to say that there's a difference in where Blue Cross is under federal regulation or standard, whereas Benistar is state? If it's so, can you tell me what the difference is for a company being under a state and a company being under a federal?
Again, trying to stay out of the weeds too much. The current program, the state regulation just means the Texas Department of Insurance oversees the basic plan designs and as far as turnaround time for claim submission and payment, things like that. With a Medicare Advantage program, it's under the auspices of CMS, which is Medicare, Centers for Medicare and Medicaid Services. It just means that no matter where your retiree lives, the standards are the same for a plan that I would offer in Texas or Oklahoma or any other state in the union, whereas a program that you currently have, if they offered it to somebody in a different state, it could look a little bit different. It really has no impact on the day-to-day activities of the retiree, the county, or the administration of it. That's the most simplistic way I can try to describe it. I don't know if that helps or not.
But when you're talking about fully insured plans, which the Medicare Advantage plan is a fully insured plan, it has to be licensed and filed with the state. It's just part of the requirements. With regards to the Medicare supplement plan, CMS, Medicare is primary. All the claims run through CMS. And so that's a federal program that's managed on the federal level. So you've got, that program is not specific to Texas. The supplement plan is not filed with the state insurance department, but from a perspective of a retiree, you're not going to see any difference in that's kind of behind the scenes as to who's taking charge of regulating the rules of that plan and how the state insurance department has certain under its umbrella, certain things that it controls. And then other items that are not under that are under the federal requirements. And so you're not going to see any differences as far as eligibility. What Brian was mentioning is that if you were to take Blue Cross's Medicare Advantage plan and you had it in a different state, their insurance laws might require something slightly different, but it's going to be subtle and it's not going to be anything material in nature.
Let me that's get it backwards.
Okay.
The Advantage plan is going to be the same no matter what state it's in. The biggest difference between a state regulated and a federally regulated program is, I would say at the member level, if they have a disagreement with the plan, there's a much more structured and quicker process for what they call appeals and grievances. It is very cut and dry. It is in the member's favor for those sorts of things, if they don't agree with a decision or an outcome that was reached by the plan, they have a more robust process to appeal a decision really than they do at the state level, which is the supplemental plan. That would be the biggest difference. And here again, you don't see that very often. There aren't that many appeals. But that's, to me, would be the biggest difference, is that under the federal regulation, there are a more robust system in there for protections for the member rather than the other way. Protect the plan. We have to justify why we made a decision in a federal sense. And it is very, anytime somebody calls in to customer service, if they're questioning the way a claim was paid, they're given the information. If you do not agree with this, here's how you appeal this decision that was made. So, and we're required to do that by federal law. It's at the state level, a lot of times they'll say, refer to your plan document. Okay. So then that retiree's got to go in and they got to look back here on page 94 and say, I think this is how I did it. They don't get as much help. There are more protections built in at a federal level than there are necessarily at state.
So if you're filing a claim, if everything is under the umbrella as far as federal, Medicare, and Blue Cross, you're just fighting the same system, as opposed to if you stay with state and Medicare is under federal, you have a better chance, would you say? As far as, I would think that under federal, it'd be the same.
I would put it this way, and again, this is anecdotal, this is personal, based on being in this, I've been in the health insurance world for 40 years. So I've worked with active, I've worked with retiree. There are more protections built in a federally based CMS regulated program. It's more in the member's favor than the insurer's favor. And I don't know how to make it any, how to say it any other way. It's more in the member's favor if it's a Medicare Advantage than if it's a supplemental plan. And here's why. If I have a supplemental plan, I've got CMS says plan F is this, okay? So I may have to go there first, then I have to go to the state. It's a more involved and longer process than what it would be with a Medicare Advantage program. There's just more safeguards and more guardrails built in for the member's protection.
Well, and so let me, and I'd like to try to make sure, Delia, I would like to make sure, figure out what the question is and get some additional information and come back to that. I don't think, from a perspective of the plan that we currently have and the plan that we're looking at from Blue Cross Blue Shield, federal oversight or state oversight is a material difference in the two plans. The difference in the plans that's going to be meaningful for retirees is how Blue Cross manages the care under the plan. And so if there's, trying to require individuals to make sure they go through certain step therapy before they go to a surgery and that type of, Blue Cross is going to manage that risk. It's going to be very similar to on an active account. We've got Liberty County's medical plan is a self-funded plan. Self-funded plans are not regulated by the state because it's self-insured. And the reinsurance piece is not a state piece. So there are certain things that we don't have to be subject to. But then you go down the street to a small employer that's not self-funded, that insurance plan with Blue Cross Blue Shield looks the same. You get the same looking card, you go to the doctor, it operates the same way, it goes through the same process, but it's actually regulated by the state because it's a fully insured plan.
Yeah, it just worried me when you said about the doctors not accepting Blue Cross and Blue Shield, as far as that.
So
I don't want to go to a doctor and him not taking it because it is Blue Cross and Blue Shield,
So
as opposed to Medicare.
one of the things I asked Brian, and don't know if you've been able to, but they have a public entity that's been with this plan, this open access plan for 5 years now. And it's not a Gallagher client, but if they're able to get a reference that we can contact them and see how that plan has worked for their retirees, I think would be a good step before we make that final decision.
Yes, I'd like to, I hope that y'all would be.
Absolutely.
I'll get the contact information here. I'm not gonna open it up for everybody to give them a call.
We'll get
I'll
Kim's
get-
office will be able to
I
reach out to them.
reached out to my client late last night. I had not heard back from him when I walked in this morning, but I should have a response later today. And I'll get with Chuck and we'll coordinate that so that a call can be made. And hopefully address that situation.
99.9% of the time, when a doctor says they don't accept Blue Cross, it's a misunderstanding between Medicare Advantage open access plan versus someone coming in with a Blue Cross card and they say, hey, we're not in Blue Cross's network, we don't accept Blue Cross. But once Blue Cross reaches out to that provider and explains, hey, we actually don't need you to be in our network. You are already accepting Medicare assignment under their old plan. All you have to do is accept that assignment, but you send the bill to us instead of sending the bill to Medicare. We will pay you the whole piece of the pie, not the portion that Medicare pays, and then Hartford right now fills in the gaps with that supplement plan. So it's actually better for the provider, and a lot of that is just an education process where it's like, hey, you're gonna get paid quicker, you're gonna get paid the same amount, and you just have to be able to accept assignment, and here's where you send the bill. You don't have to sign any contract to be in our network. We don't require a contract. That process, 99.9% of the time, if there's an issue, it has to do with them not understanding how this plan works, and that they don't have to be in Blue Cross's network.
I guess we'll know when we talk to the present company or entity that's using them
Yes.
right now.
Yeah.
Okay.
Okay.
If that's how it's working.
Yeah, and one thing, just to kind of address that a little bit, is one of the good thing to keep in mind is we're in the general Houston metro area. Sure. Okay. But we're in the greater Houston area, so we're starting from a big population of contracted doctors to start with. We're not out in Big Spring. Okay, we're 100 miles from any major metropolitan area, so it's we have fewer instances of that sort of situation. That we're gonna address that further. So
Thank you.
Any other questions? Brian, I really appreciate you coming out.
I appreciate again the opportunity, and anything else that you want to run through Chuck, he'll get in touch with me and we'll get back with you over the next few days. And again, thank you all very much. Thank you. Thank you.
So one other thing that we discussed last year, this is just specific to the retiree contribution. Let's keep one for myself. If you recall, last year, we increased the employee on the active plan from $24 and change to $50 a month. And we made the decision Liberty County made the decision to also increase the retiree-only contribution to that $50 a month. What we did not do is we did not touch the dependent tiers. Now, there's not a ton of retirees that are enrolled in the spouse or children or family, but we did increase the dependent tiers under the plan last year for the active plan. And so just for consideration, wanted to kind of get your mindset thinking about whether or not you wanted to also look at increasing the cost. So essentially, if you've got somebody that was a retiree only, we increased their costs about $25 a month. But someone who was enrolled in a retiree plus spouse last year, they didn't see an increase. So we didn't even increase it to $25 that we increased to retiree only. And if you've got two people on the plan, the example I'm showing here is essentially raising it $25 per person under employee spouse So $50 a month, $50 a month for retiree child and $75 for retiree family. It's just to take a look at what the cost impact would be and the number of employees or retirees that are currently in those tiers. But just wanted to bring that to your attention that we did not look at that last year. And we're discussing on the active plan is also increasing the dependent tier costs as well under the active plan, which we'll get to here in a second. So.
Wayne, you got a question?
Yeah, it went up on the employee, retiree only, didn't go up any for retiree and.
We did not. That decision, that was not, we did not last year. Which is why I'm bringing that. Is there a question?
Seems weird.
Yeah, I think, when we met with Commissioner's Court last year, it was, let's keep the retiree only equal, but there was not a clear direction as to what we wanted to do for the dependents. Because the dependent costs for the active plan are different than the dependent costs for the retiree plan. So we increased the dependent costs, but on the retiree plan, dependents already pick up a bigger portion for those tiers. So we went up to, I think, $200 for employee and spouse. But right now you're already at $383. So there wasn't a clear direction as to what we were supposed to do for those dependent tiers. And there was not a significant number of individuals on that plan. And so we're kind of circling back and kind of clarifying that piece now as to what we want to do. We did not increase that cost to the retirees that are enrolled in those dependent tiers last year.
Realistically, how many retirees have children on there?
There's only
Well,
one.
that's what I was.
Is this including the county's contribution or just the employees?
This is just the employees. I actually was looking at trying to model the county contribution. It gets muddy because out of that 12 that are retiree and spouse, 7 of those retirees are split. You got 7 that are on the self-funded plan because if one of the individuals is under 65 and one is over 65, you're paying just the supplement cost for those that are on the Benestar plan right now. And then the ones that are under 65 are flowing through the self-funded plan. So it's a little harder to show what the county cost is because there's a lot of different ways you have to slice it because of each individual retiree. So I wanted to show this specifically to what we're collecting from the retirees. And not muddy the water with the employer costs because the self-funded is more of a projection. There's an actual fixed cost that you pay for the retiree supplement plan because that's a fully insured. We don't have to we're not making decisions here. I just wanted to get some feedback so that when we go back to the benefits committee and come back to see you guys in middle of September, we're making a recommendation that's in line with what if there's any concerns about what we're talking about here. Any questions? Okay. Let's keep on. So under the medical plan, we have, I think there was a workshop that took place. There's actually been an agenda item on one of the commissioners' court table with regards to changing the cost to the retiree contributions under the plan. And so we did, I think the numbers that we've shown in the past have shown all of the individuals enrolled in the plan, which I think overstates it because there are a number of retirees that are also included in those numbers. And if we're increasing the cost to active participants, wanted to take a look at what that actual cost would be if we're looking only at the active employees. So this contribution scenario, first page, this models out the $100. So we're increasing these by 100. You can see on the very far right-hand side, the employee is not changing. But the dependent cost would be going up $100 a month. So this was at the direction or suggestion from one of the workshops as a recommendation, that we wanted to look at essentially raising the cost. Now, I do want to point out, when we do that, you're looking at about a 50% increase for that spouse. It's a 50% increase to the spouse costs, almost 60% to those enrolled in employee and children. And then it's a $100, 40% increase for those enrolled in employee family. We can model this any number of ways. So if we're trying to get to a specific cost savings, we can take a look at other ways of shifting that cost under the plan. But the second page essentially shows no change in what the cost to the county would be versus what we're collecting right now. So it would, if we shift that $100 and nobody changes enrollment, we'd be taking in an additional $230,000 in premiums from the employees, because these are the employees that are on the active plan.
Right, what we have in the budget is $100 on the employee side and $100 on the county side.
On here, we've got employee and spouse 100, employee, children 100, employee and family 100, with no increase on employee only.
And we actually got $100 on the county side. 100 on the employee.
Correct. So and the numbers that we're showing here are based on the projections that we got from our underwriting team, but we can, from a budgeting perspective and how the county is budgeting, the $100 on the employer side, definitely get the budget rate set just so that the $100 is increased for the county as well. Okay. And then I just want to, from a cost perspective, wanted to show, we had modeled some, I think the initial workshop had some different things we wanted to take a look at. I think we may have tabled a lot of those discussion points, but we can always, there's two ways that you shift cost, or, you can increase the cost of the premiums, and that's everybody that's enrolled in those tiers pays those additional premiums. But then you can also make plan design changes, which then shifts the costs more so towards those that are utilizing the plan, and those that are not utilizing the plan don't see the increase in their premiums. And you can do a combination of both as well. This first page is just essentially our projection from our underwriting team as to what the projected cost would be for next year. This is not what we would necessarily be budgeting, as Dwayne was alluding to. But on page 16, we had them model some different plan design changes. And essentially, we had talked about reducing, so the last two lines, our current HRA, which is Blue Cross calls it an HCA. It's those funds that the plan pays towards your medical costs at the beginning, towards your prescriptions. Right now, the county's putting in $1,000 if you're enrolled in employee only, and $1,500 if you're enrolled in employee plus dependents. If you were to reduce that seed by 500 respectively, so the individual would get 500 seed in that account, and then 1,000, and if you're enrolled in employee dependent, that would create a $200,000 savings if we wanted to make that plan design change, or do a combination of that and employee contribution changes. So wanted to just give you some food for thought as far as some things we could do from a plan design option. We also had, and we can go down that path if we want. Last year, we kind of looked at a dual plan option and decided we didn't want to do that. If we wanted to, we could have the exact same plan design.
What are we currently at? 500,000?
Over here on the left, right here, it's 1,000 and 1,500.
Correct.
So the 1,000 is for if you're employee only, and then if you're an employee and spouse, employee and family, employee and child, that's 1,500. And then the proposed, if we were to reduce it by 500, that second to last line, it's about 202. If we made everybody, regardless of what tier, at 500, it would be an additional $100,000 in savings.
Definitely don't want to lower it.
Okay. We had them run those numbers. I think some of the discussion that we had at that one workshop was, hey, let's take a look at it and see what that would do. If you wanted to look at it, maybe not 500, you wanted to just lower 250. We can, the savings is going to be kind of in line with, it's half the savings if you lower it by half the amount. But wanted to have the discussion. Is there interest in trying to make some plan design changes and contributions? Do we want to stick with the raising 100 for the dependent tiers and 100 for the county? What are your thoughts? What do we need to take back to the?
I think right now we're sticking with 100 and 100. That's what's in the budget. I think we had to make a decision. And for all practical purposes, the budget was set. We're just waiting on things to vote. So now we got to make what you have fit into our budget. Is that the way you're looking at it too, Dwayne?
And we, as you know, our health insurance fund is underfunded for years. I don't know what the equilibrium is, but we need to start working towards the equilibrium of proper. I think me and the county judge and commission talk, just running the numbers. I think, what I was saying is you gotta eat an elephant one bite at a time. I think 100 is a good first.
I think, and it probably would help for us to get together as far as the numbers that we're looking at. In the past, we have shown, we've taken the enrollment in that self-funded plan. There's about 40 to 50 employees or retirees that are in those numbers that don't tie into these contributions that we're collecting, but they're driving those costs.
They print off the print out who's on the action plan. Hopefully, demographics for the county employees get more favorable.
Yeah.
Maybe.
Well, and I think, just the conversation, it was, if we pull it from payroll, because the payroll doesn't capture the retirees. If we're pulling who's actually enrolled and we're budgeting based on that, I just want to make sure that we're looking at that.
Yeah, I work with the numbers for the active.
Those are the items that I really wanted to kind of address and just kind of get out in front of you guys today.
Chad, can we kind of take a step back and
Sure.
go back to the RFP process and all that? Because Commissioner Kowalski asked me earlier about TAC and whether they were presented with the opportunity to bid and whether they took advantage of that opportunity. And I told him, yes, that did happen and they declined to bid on it. I know Harold has all the details of the paperwork, but would you address that?
Sure. No, absolutely. The process we go through, we publish it in the newspaper 2 weeks in a row. We get a lot of different inquiries. So there's that piece that, puts everyone on notice if they're looking for those types of bids, that they can request the RFP. I received direction from Kim and Harold that we needed to send the RFP to TAC. I sent it to them immediately. And they felt like they didn't have enough time to get it in by the deadline and declined to quote because of that. I did provide them feedback that they had over a week to get the information and provide a proposal, but they were not able to provide a proposal or chose not to. They declined to quote.
So it had nothing to do with our deficit or anything else as far as the county goes. It just said they did not have time.
That was their stance. They did not have time. And from a time perspective, trying to get decisions made and get in front of Commissioner's Court to make a decision how to proceed and then implement anything that we're making changes for and meet that open enrollment deadline. To extend the deadline would have put in jeopardy some of the other things that we're trying to accomplish. But we did weigh that in and we discussed it. But they did have the RFP more than a week in advance. They did not have it as long as other individuals that received it in advance, but if they had requested it, they would have received it as soon as it was available. So. But yeah, they didn't say that they were declining to quote because of anything to do with deficit or for any other reason. It was time.
Okay, so the next thing, if we could, if we could just kind of hit a little summary of what is on the table with regard to the retiree coverage.
Okay.
So back to that one, the front page is what the retirees currently have. And from my perspective and perspective of my colleagues in my office, we rarely get a phone call from a retiree who's having a problem on this plan. All of their doctors participate in this network, so to speak, and
The current plan you're talking about.
the current plan, the Hartford Benistar plan that we have now. What I
Talking about
think,
on page 2 of our first pamphlet, correct?
This first page that
The
has
first
the
page.
Hartford
Yes.
the
Benistar.
first
Yes.
page, yeah. The savings on that, as you can see, is the $2,600. So in order to keep the plan that we have now, we can save about $2,600 is the estimate if we continue with that into 2022. The plan that the gentleman was here speaking about on the second page, the Blue Cross, the potential savings on the table there is it's almost $250,000. What scares me about that plan is all of the things that he just talked about. One thing that scares me is that the talk about how the insurance company is going to walk them through it and help them through it. And sometimes what in my mind that translates to is that the insurance company starts to tell the doctors what they're going to do or not do, and it gets a little bit too much management, and where the doctor sort of gets pushed to the side and the insurance company takes over. That's the part of that concerns me. Also the billing and the complications with that, because, you know, the retirees having to jump through those hoops is a difficult situation. The third option on the plan that we haven't talked about very much, to me seems a little more palatable because it also is a big savings, almost $200,000. It's not as big of a savings as the move to Blue Cross, but it also ensures that the medications that the retirees are taking now will continue to be covered, where the Blue Cross does not ensure that. So
Where's
then
the third option?
the
Side by
Benistar
side.
plan with the
This
Cigna,
right side of the
Cigna,
page right there. That one on the right-hand side.
This is the Blue Cross Blue Shield.
That one's the Cigna. And since Cigna owns Express Scripts, the prescription pharmacy is the exact same. So, I mean, there's still the potential on the Medicare side, the medical side, that it still has to have a doctor that's willing to accept Medicare assignment and bill Cigna instead of Blue Cross. And it is a managed plan. So Cigna's going to be taking on the risk associated with that plan. And so there's going to be some changes as far as how the plan operates, but biggest noise that we received back when we had the Medicare Advantage plan before moving to Benistar was, I've got a doctor that is not, except, you know, I can't go to this doctor because it's not in this HMO network, my Advantage plan. So those types of networks are actually a network of doctors, and if they are not in that network, they couldn't go to anybody that they wanted to. This plan and Blue Cross's plan conceptually allowing anyone to go to a doctor that accepts assignment for Medicare. There's always a doctor out there that may have, you know, for the same reason they may not like Blue Cross, they may not accept Cigna, but it's more of an education, and 99.9% of the time it is, they don't understand that even if they're not contracted with Cigna, that they can get paid and get paid faster under that plan through Cigna. Now, if someone got a knee replacement under the supplement plan and Medicare's like, yep, it's covered, and there's not a whole lot of, you know, pardon the pun, step therapy with regards to the knee replacement, but then you go to get a knee replacement under the new plan, there may be some processes that, you know, it's actually better for them to try physical therapy and go through certain process, because surgery can be very invasive, but these plans tend to be more involved in managing the care of the patients, which some retirees don't like that. They like being able to just have the plan cover what it's going to cover. But we did take the biggest piece. So if you take all the people that are retirees on their plan the pharmacy benefit is the most utilized. Most retirees have at least 5 prescriptions or more that they're having filled. And if there's one retiree that has a prescription that they're currently having covered under the plan that's not under the formulary for the new plan, that's going to be where you're going to get like, the majority of your noise is going to be tied to that. And I think if you're wanting to try to look at savings and minimize the noise, I feel more comfortable recommending the Cigna Express Scripts option because we take that piece out. There's still potential for noise. So there's going to be education for the retirees, helping them understand how to use the Cigna plan. But we also keep the Benistar piece in play. So Benistar layers on top of it. They've got a customer service number. They're doing the outreach. They're doing the welcome kits. They're doing a lot of that member education. And there's been a lot of positive feedback we've received from the retirees with regards to how the experience is with Benistar.
And that's what we currently use.
Benistar is the third-party administrator that pulls in Hartford and Express Scripts right now, and that's who we currently use. The only thing that we're switching out of that equation is we're removing Hartford, which is a supplement plan that just reimburses whatever Medicare doesn't. Medicare processes the claim, and then it gets kicked over to Hartford. Cigna would actually process the claim and pay the claim, the full claim. And it's a very rich plan. If you look at the benefit plan, there's no co-pays. It really covers pretty much everything. The noise you're going to get is if there's an individual that has a doctor. But kind of to Brian's point, we're already in an area where most doctors are contracted with Cigna and Blue Cross. There's not a lot of doctors that aren't. And those doctors that aren't, if they're accepting Medicare, they can accept this plan as long as they're willing to bill Cigna. They can't, we'll find out. Another thing that I did put on here, because this came in at 7 o'clock last night, they got it rate guaranteed for 2 years from both Express Scripts and from Cigna. So we can lock in that savings for 2 years. If we have a lot of noise, I'm trying to make sure I'm asking all the right questions so that we don't have a situation where we find out after the fact that retirees are just up in arms and hate the plan. I feel like I've gone through and I've asked the questions and I feel pretty comfortable recommending this, but if we just hate this option, we can always go back to a Medicare supplement plan next year and learn from that. But it's going to be, I don't have the ability to get a disruption report because it's under 100 employees or retirees to see what doctors people are currently going to and what that disruption would look like.
And so a big part of the reason why this has gone from the insurance committee to the commissioners for this workshop is because of that problem. Because I forget which year it was, but we moved to the Medicare Advantage program and retirees were very upset about it. A number of retirees got off the plan. So what's on the table here is monetary savings. At what cost? At what cost to the retirees? At what cost to the doctors, that they see? So what
Several years ago, whenever everybody got off, they went to that Advantage plan.
Right, because of the proposed savings, but then, so many of them weren't able to see the doctors or there was the billing problem or whatever. So what I'm saying to you is that the county can save this money, but it may be at the cost of the retirees.
Yeah. That's the one that's managed by the federal government. That's not much comfort to me.
I'm with you.
So that's what, that the insurance company the insurance committee basically is saying, look, this is what we got. It's difficult to make that recommendation because, you're balancing the taxpayer money where you're saying, we could potentially save this, but then you've got retirees on the plan who have dedicated their lives to working for the county and, potentially putting their life on the line for the county, and you're not letting them see the doctor that they want to see. So those
Exactly.
Those are the
Yeah, I don't think when it
those
comes
are hard. They're hard decisions to make, and that's why
to insurance, I don't think it's a place to try to save money. As far as taking benefits away. to save money on here. So which one is basically the insurance committee advising us to take?
The insurance committee has not taken a vote on this. We wanted to bring it to the commissioners to say, look, this is a hard decision. It's a hard decision.
A recommendation?
A recommendation,
Do what?
what's that, Joey?
I would do Benestar, and I'm on the committee.
Benestar, so there's two Benestar options. There's the
They're
current
the one
Benestar
with
option
the Cigna.
with the Cigna.
That's the one I would
Andy,
recommend.
Is that what we're on now?
So there's, let me clarify. Benestar is administering the plan as it is right now, with Hartford handling the medical supplement and Express Scripts handling the Part D pharmacy plan. The option on the table that I would not recommend Blue Cross. I would recommend, if we're looking at, and we have any questions that we need to vet with Cigna to make sure we feel comfortable with it, we can go and get that information and have that ready to present when we meet. But the plan allows individuals to see anybody that accepts assignment, which is different than the issues we had previously. There is a chance that there's a doctor that might not want to bill Cigna. So I think we've minimized the medical noise or potential noise. There's always the change. Retirees don't like change. People don't. I mean, I don't like change. That's not, but so communicating that change and getting someone to understand how the new benefit works is probably the real biggest piece. But there's the potential for some significant savings. We've taken the noise or the change from the pharmacy side off the table. We've still got Benestar, so that's a familiar name for the retirees. The number would stay the same. They'd still be able to reach out to Benestar. So there's a little bit of consistency with those two pieces. And then we're looking at $180,000, $185,000 in savings if we were to move them. And it is not my recommendation to create savings on the backs of retirees.
Exactly.
Not what we're trying to do. We're not trying to come in and say, hey, as a matter of fact, I'm trying to poke every hole in this process to say, hey, why is there so much savings and at what cost? And I'm probably overemphasizing the potential disruption with regards to the doctors that don't want to bill Cigna, because that's a potential complaint that's going to come up. But I think it's going to be more so educating the retirees and having them understand what the change is. Having Benestar and Express Scripts stay in the picture really minimizes what's changing and helps us focus on that piece of education. And so the question for the commissioners and for the benefits committee as to what we recommend is, do we take this plan knowing that it's an open access plan? It's not like the Medicare Advantage plan we had previously, and recognize that there's a significant amount of savings that we need to consider. But I think that's a decision that Liberty County needs to make as far as what you're comfortable with. And Gallagher will do our best to make sure we educate the retirees and we equip the county with all the materials and hold Benestar and Cigna accountable for making sure they follow up on their promises that they've committed to. So it's why we wanted to have a workshop to kind of discuss it, because it's not an easy decision. I think there's a compelling argument to make that recommendation. But there's also, hey, Benestar came back with a rate. We didn't have to even get them down. I mean, we said, give us a competitive offer. We've seen increases from them every year. Keeping the exact same plan, they didn't raise the cost. So if we didn't have any other options on the table, this would be a very attractive option for us. We just happen to have some savings on the table, and if we're looking for ways to try to, and they've locked that in for 2 years. So you don't typically get a 2-year rate guarantee on these types of benefits. So and I'm happy to go back to Cigna. I'm happy to go, if there's any questions or concerns that you want additional clarification or answers for, we can get that, we'll present it to the benefits committee so that they have those answers. And when we come to commissioner's court, we can have the two options available. We can give you the additional details and you guys can make a decision at that time.
There's no way to get them to do a disruption report because of the low number of participants. Is that the situation?
So this, I will say the Cigna one came through, we've been discussing with them. I got that late last night. Because Benestar is currently administering the plan and they may have a little more access to the information. And if it means they would keep the business, and I tell them that they're at risk of losing the business to Blue Cross, they might be able to run the disruption report. I haven't had a chance to flesh that piece out. But that being said, the claims are actually flowing through Medicare. I don't really know if we're able to pull a report unless they get processed through the Hartford side. So if they can pull it, I will ask. I'm going to ask for them to give us some additional information. But that doesn't mean that there's still not one doctor out there that somebody goes to that they haven't gone to in a while. But I will definitely look at that. We'll get some additional information from them. I really appreciate your time, guys. If you have any other questions, obviously, Tim and I will be in contact and we'll be meeting. But let me know if you think of anything after the meeting. Appreciate it.
Good deal. Neely, no more questions? Come on.
No, that's it.
Joanne, what about you?
No,
No?
don't have any.
Any? Don't say anything? You don't throw any kind of Hail Marys out there? All right. All right. Thank you, Chuck.
Pleasure.
So much.
Thanks, Leon.
All right. We're dismissed.